This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending in pediatric neurosurgery.
And I'm Dr. Ilara, a research fellow. Today we're looking at a fascinating new study from the journal Child's Nervous System, published in 2026. It's titled Postoperative Raised ICP After Minimally Invasive Surgery for Monosutural Craniosynostosis, coming out of the Fondazione Policlinico Universitate a Gemelli in Rome.
This is a timely topic, Ilara. We've seen a massive shift over the last 30 years toward minimally invasive craniectomies, or MIC, for monosutural cases. The trend is clearly toward less and less invasive procedures. But as we move away from traditional open cranial vault remodeling, or OCVR, we have to ask ourselves, are we sacrificing the primary functional goal of the surgery, which is the prevention of raised intracranial pressure?
Exactly. The paper points out that while we have plenty of data on surgical outcomes, like the cephalic index, transfusion rates, and hospital stay, or even cosmetic and neuropsychological outcomes, we're actually missing a systematic assessment of the risk of postoperative intracranial hypertension.
It's an interesting blind spot. We talk about the look of the head and the ease of the surgery, but what about the pressure? So walk us through how the authors, Martinelli and her colleagues, approach this.
They used a dual-track approach. First, they performed a systematic review adhering to PRISMA guidelines. They used the PICO framework to ask, in patients with craniosynostosis undergoing MIC, is the risk of postoperative intracranial hypertension higher than in other procedures? They searched PubMed for everything from endoscopic strip craniectomy to raised ICP.
And the second track?
That was their own institutional experience at Gemelli. They looked at a cohort of scaphocephalic children operated on consecutively between 2010 and 2023. They compared their MIC cases, specifically suturectomies and partial remodeling without postoperative helmeting, to a control group of children who underwent OCVR during the same period.
That's a solid 13-year window for the personal experience side. What did they find in the literature review?
They ended up with 14 relevant studies, mostly retrospective, covering a total of 3,048 patients. Out of the 2,297 children treated by MIC, about 2.8%, that's 65 cases, showed postoperative raised ICP. The overall reoperation rate for the MIC group was 4.4%.
4.4% for reoperation. How does that compare to the open remodeling cases in the literature?
For the 751 OCVR cases analyzed in those studies, the risk of reoperation varied from 0.95% to 7.1%. So at first glance, the MIC and OCVR cohorts seemed to be in the same ballpark, but the review actually found some interesting nuances depending on the specific MIC technique used.
Tell me about those variations. Not all minimally invasive surgeries are created equal, right?
Right. The risk of reoperation was notably higher in modified or spring-assisted strip craniectomies, where the rates ranged from 2.4% all the way up to 14.6%. Compare that to endoscopy-assisted craniectomies, which sat at a much steadier 2.4%.
That's a significant spread for the spring-assisted group. It makes you wonder if the mechanical expansion of the springs is always sufficient for the brain's growth in the long term, or if those modified techniques are leaving too much of the restricted bone behind. Now, what about their personal experience in Rome? Did their data mirror the literature?
Very closely. They focused specifically on sagittal synostosis because of the higher inherent risk of raised ICP. For their MIC group, the reoperation rate for raised ICP was 1.5%. For their OCVR group, it was 0.8%.
So 1.5% versus 0.8%. Did that reach statistical significance?
No, the p-value was greater than 0.05. Using the chi-square and student t-test, they found no significant difference between the two surgical approaches in terms of postoperative ICP risk.
That's a reassuring finding for those of us moving toward MIC. It suggests that the minimal approach isn't necessarily a lesser approach when it comes to volume expansion. However, the authors did highlight some major limitations in the current body of research, didn't they?
They did. And this is the part our resident listeners should really pay attention to. The biggest issue is the lack of standardized methods for postoperative screening. In many of these studies, they weren't using quantitative ICP monitors, which makes sense, as you wouldn't routinely place a monitor in a stable post-op patient. Instead, they relied on clinical signs, fundoscopy for papilledema, and imaging.
Right, and as we know, clinical signs and fundoscopy can be late indicators. If we aren't looking for raised ICP systematically, we might only be catching the most symptomatic cases. The authors also mentioned that many studies didn't even specify the reason for reoperation. Was it for cosmetics, or was it truly for intracranial hypertension?
Exactly. That ambiguity makes it hard to pin down the true incidence. Plus, most of the data is retrospective.
There's another study mentioned in the introduction by Da Costa and colleagues that I think is worth highlighting. They looked at 1,564 children and compared less invasive procedures, meaning suturectomies under 2 centimeters with no lateral osteotomies, against more invasive procedures, like larger suturectomies with lateral osteotomies.
I remember that one. They found that the less invasive versions were comparable in terms of cephalic index gain and how long the child needed helmet therapy, but they had a lower risk of blood transfusion. It really reinforces the trend we're seeing. Less is often more.
It is, but the Martinelli paper brings us back to the functional goal. We can get a great-looking head with a 1.5 centimeter strip craniectomy, but we have to ensure the brain has room to breathe. Their conclusion is that the risk of postoperative raised ICP is relatively low for monosutural synostosis across the board, regardless of whether you do MIC or OCVR.
And they noted that their MIC technique at Gemelli involves suturectomies and partial remodeling without postoperative helmeting for children under 5 to 6 months. Even without the helmet to guide growth, their reoperation rate remained very low at 1.5%.
That's an important detail. It suggests that the surgical release itself, if done correctly, might be doing the heavy lifting. So if you're a resident or a fellow listening to this, what's the takeaway?
I think the takeaway is that while MIC is safe and effective, we can't be complacent about long-term follow-up. Since the risk of reoperation for raised ICP can be up to 14.6% in some specific techniques like spring-assisted craniectomy, we need to be vigilant.
And we need better data. The authors are calling for more standardized postoperative screening and clearer reporting on why these kids are going back to the OR.
They really emphasize that missing information in the literature was a hurdle for this review. If we don't record why we are reoperating, we can't improve the primary procedure.
Precisely. So in summary, minimally invasive techniques are holding their own against open remodeling when it comes to ICP, but the gold standard for how we monitor these children postoperatively is still evolving.
It's a call for more prospective studies with better defined metrics.
Well, that's all the time we have for today. Fascinating study. Ilara, thanks for breaking down the numbers.
My pleasure, Dr. Aris.
To our listeners, you can find the full article in the May 2026 issue of Child's Nervous System. Until next time, keep learning and keep operating. This is the Neurosurgery Hub podcast.